So why is it important to reduce fall risk? Well, there's lots of research around the statistics around falls. We know that falls are occurring quite regularly in the community. So 1 in 3 community dwellers over 65 years will fall each year. That's a pretty high percentage. When we move into the aged care space, that number turns into 1 in 2, so very high. And then for people over the age of 85, again, they fall into that 1 in 2 category. So falls are happening quite frequently, or more frequently than we would like. Once we introduce a cognitive impairment, such as a diagnosis of dementia, that rate increases to 70 to 80%. So obviously we would like to be able to bring down these figures. Falls are also the leading cause of hospitalised injury. They're the most common cause of injury-related deaths for people over 65, and they account for 1 in 5 of all fatal injuries. So very important conversation to be having, and a very important topic for us to be exploring as educators and as health professionals. And if that's not bad enough, 90% of hip fractures result from falls, so catastrophic events post-fall, and 50% fatality rate of hospitalised falls within 1 year. So once somebody has that fall, even if they recover post-surgery, there's a very high incidence of fatality in that 12 months post the fall. So we want to be doing better. So what are some of the contributing factors? So these are our 12 highest risk factors, or things that tend to contribute to falls. So things like a history of previous falls or a fear of falling, urinary incontinence, taking 9 or more medications or polypharmacy, arrhythmias and cardiac issues, cognitive decline, gait or mobility issues, balance impairments, vision impairments, poor footwear, unsafe environment, vitamin D deficiency, and strength impairments. Now, it's important to point out that these things don't all work in isolation. We know that falls are multifactorial. They're all interacting with each other to increase falls risk. And if you think about the older population that we're working with, most of them are going to have a good handful of those at least. So there's many factors that are contributing to them. Now, when we think about some of these contributing factors, now's a good time to touch on our falls assessments that we're doing within most of our environments. So for us in the aged care space, it's often our FRATs, falls risk assessments. For me as a physio, I'm thinking about Bergs. We love to categorize people into, say, low, medium, or high falls risk. So we give people that label. What I don't see, or what doesn't happen very regularly, is the transition from that label into any change in practice. So we've ticked that box, we've done our FRAT, we're often doing it post-fall, but we're not actually taking that information and actually using it in a useful way. I think what may be a better way to approach it is to assume that everyone, particularly in the aged care environment or potentially in other clinical environments, because people have often experienced some kind of negative health consequence as to why they're dead, if we categorize everyone as high risk, and then we put processes in place that tend to target the things that we know are increasing risk. So let's not go with low, medium, or high. Let's just go with high and be more proactive around how we're actually approaching those strategies. As well as post-fall. So when we're looking at post-fall process, we want to make sure that these are some of the things that we're considering. So for myself as a physio in the aged care space, I'll get a post-fall incident report, and it will have 2 or 3 things like the time, no injury, no head knock. But I don't really know anything else that's happened because it's probably occurred overnight or in the morning, or I just haven't been there when it's occurred. So the more information that we can get, I know Jan touched on this in her presentation as well, the more information that I can get, it then allows me to actually be more effective in how we manage that and hopefully reduce the incidents in the future. And finally, Jan, I think touched on this as well, really about bringing the team together. So particularly in the aged care space, I'm sorry to keep going back to aged care, but I think anywhere, falls often become a physio problem. Now, physios in aged care specifically are a very limited resource. Often you've got one person looking after over 100 people, and we can't be there all the time. So if we can actually work on educating our teams and actually empowering everyone to be a part of reducing the risk of falls for older people, I think we can get much better outcomes. I'm going to touch on some of the things that are easy for us to identify and hopefully empower our teams to be a part of this falls prevention journey. So here are the ways that we can impact falls. So whether as physios or carers or health professionals or family members, because that's often the family members who we care about the most. I've seen this with my parents and my grandparents. When a fall occurs, the first thing we want to do is start doing fall. Now, we love this idea of reablement. It's a great term, and it's very well intentioned. We want to do things with people. We want to get people back to doing the things that are important to them. However, what we tend to do, and it comes from a place of caring, is we start saying, we'll do that for you. Stop that, or don't get up. We got that for you. I'll grab that cup of tea. So the things that were happening, those incidental exercise or movement that was happening, all of a sudden are not occurring anymore. So we're limiting the activities the person is participating in. So don't do that anymore. Wait for me, or hold on to that, hold on to the rail, grab your walker, those sorts of things. And we're essentially reinforcing the fear. And we've touched on already that fear is actually something that increases the risk of falls. And we're going to talk about why that's the case. So be careful. You don't want to fall. We're reminding people of that falls occurred. And again, it comes from a place of love generally or care, but it can actually have negative consequences. So I challenge you all to think about dignity of risk. And I know we love dignity of risk. It's something that's quite topical. And when we think about dignity of risk, I love risk in life. Risk is what makes life fun for the most part. I love snowboarding. I'm not a good snowboarder. But every time I go snowboarding, I know there's a risk I'm going to break something. But I do it anyway because it makes life fun. All right? And just because we get older doesn't mean that we don't want to participate in the types of activities that we always found fun. We just tend to stop doing them because, one, we become too fearful, or we have people stopping us from doing them. So we want to start to talk about, how can we help? Apply those reablement principles. When are you going to get back to doing that thing that was awesome? When you get back out on the golf course? When are you going to go on another cruise? And just let people know that they're okay. The fall has occurred, but they're okay now. And we're going to be proactive. We're going to help them to plan some proactive strategies to move towards reducing their falls risk and hopefully prevent falls from happening again. So this is the fear of falling cycle. So what tends to happen here is fall occurs, and we end up with this increased fear. So at least 50% of older adults report a fear of falling or a loss of confidence post-fall, which makes sense, generally very traumatic. So we start avoiding those usual activities, and that's whether we contribute to it as carers and health professionals or friends, or whether the person just says, I don't want to do that anymore. I'm getting too old. We love that one. We're getting too old. Don't do that when no one's too old, all right? I'm going to talk about that. And we start relying more on aids or furniture for support. And by doing that, we're essentially reducing the person's balance, so vestibular function, neuromuscular function, reaction times. We're reducing their mobility. We're decreasing their strength because they're sitting more sedentary. And eventually what we're doing is just increasing falls risk. What happens if we increase falls risk? We have another fall and the whole thing starts again. So we want to try and find ways to break that. So how can we reduce falls risk? Well, here's a couple of simple things, all right? So FEAT has been around for a while, F-E-A-T. We'll get to that shortly. I've added the D, and hopefully we'll defeat falls. We won't be defeated, all right? So if you remember defeat, here's some things that come back to those 12 risk factors that most people can certainly be aware of, and we can contribute to most of these. So from a physio perspective, I like D. I like vitamin D. So there's some research that shows that it's poor statement, wasn't it? There's some research that shows that vitamin D deficiency can increase falls risk by as much as 49%. And by supplementing vitamin D, we can actually significantly reduce the person's risk of falls. Now, particularly people living in the aged care environment or people with poor mobility who are accessing home care tend to spend more time inside. They're not getting out into the garden, into their community. So most of those or many of those people already have a vitamin D deficiency. We know that vitamin D can also contribute to other poor health-related outcomes like COVID. So we want people to make sure that we're monitoring those things. So talk to your LMOs and GPs about getting those tests done. Ears is vestibular function. I just couldn't get a V in there, but we want to be focusing on vestibular function. So around 1/3 of people over the age of 65 experience dizziness or vestibular-related impairments with BPPV or your benign paroxysmal positional vertigo. Just saying that to try and sound smart. Essentially, it's most common vestibular impairment. Now, the interesting thing about BPPV is that it's quite poorly diagnosed, but pretty easy to treat. So a series of pretty simple movements that many of us would know in order to kind of clear some of those crystals within the canal in order to reduce those symptoms of dizziness and poor vestibular function. So be aware of the impact of vestibular function on falls risk. We move on to footwear. So what do our aged care residents like to wear, Jan? Yeah, nice pair of Crosbys, 10-year-old Crosbys. God forbid we spend $20 on a new pair. Comfy, but very poor. So poor tread on the bottom, poor fitting. So what we want is nice and firm fitting shoes, so laces preferably, or at least something Velcro that we can do up nice and tight. We definitely don't want open toe. We want a low gradient between the heel and the toe. We want a nice firm fitting heel, plenty of tread on the bottom. All right. So when you're talking to your teams about which shoes to pick, often there's a few options. Generally the slip-ons get the priority. Try and go with those ones that fit a little bit better. while we're talking about footwear, obviously healthy feet are important for falls prevention as well. So you get that multidisciplinary team involved, try and get your podiatrist coming in. And if you're in the aged care environment, try and get them to look beyond the nails, all right? And try and look a little bit more at the whole foot and how that might contribute. Environment. So lots of things that we can do from an environmental perspective. So obviously we all know slips, trips, and cords and what have you. From choice of furniture, from a physio perspective, doing lots of manual handling training, but I'm sure it happens everywhere, particularly within the home. Looking at appropriate choices. So something that's a little bit higher so people can stand up from, something with some arms that people can push up from. Other things to think about, things like lighting, making sure that people can see where they're going. Safe access to outdoor areas, things like that. When we think about aids, we want appropriate prescription of mobility aids. So whether that's a walking stick or a four-wheel walker, forearm support frame, or any other aid. Environmental, think about people within the home, get your OTs involved. All right, so looking at creating safe spaces within the home, so whether that's installation of a rail, getting a bathroom readjusted. So be proactive if we're working with people within those environments, setting up environments as safely as possible. Back to aids. So if we're thinking about prescribing aids, obviously it's great if you can refer on to a physio or somebody who will prescribe the aid appropriately. But if you're working with people, look for things like brakes that are working well, wheels that are working well, ability to kind of move things around, plenty of padding on the bottom of that walking stick. And if you're trying to measure them up, the height should be somewhere around wrist heights. Now, I know some of the people we work with will want to have them up here or right down here, and no matter what you say, we can't change their mind. But if you want to go with a nice principle to live by, somewhere around that wrist height down by the side. And then we want visual and hearing aids. So making sure we've got our hearing aids in. It's much easier to work with people, particularly from a manual handling perspective, if they know what you're saying. And you can ask them how they're going as well. That's always a nice way to start rather than go and rush it in with our task orientation. So definitely want to build that rapport with people. But also anyone who's a little blind like myself, it's much easier to get down the hallway at night if I can see where I'm going. So I always like to basically spend a bit of time cleaning people's glasses and making sure it's on before we support them. Make sure they're within reach, all right? The mobility aid and the glasses are not much good over against the wall, all right? And if somebody's at a higher risk of falls, if we put their mobility aid against the wall, they're even more likely to fall. So make sure we have it close, all right? Understand that the temptation is, oh no, it's up against the wall, the person won't stand up. That tends to not be the case. We want it nice and close if possible. And finally, toileting. So if somebody has urinary incontinence, it increases their risk somewhere between 30 to 40% roughly. It also increases their risk of fracture by around 35%. So we want to be able to manage this as best as possible. Obviously, I'm not a nurse, but managing incontinence as well as we possibly can with appropriate aids. And then looking at proactive strategies. So whether that's toileting schedules or maybe reducing hydration or water intake, particularly in the afternoon. So we're limiting the person's need to get up and down constantly throughout the night. So just a few simple things and a nice, easy way to remember. A few special mentions, nutrition. Jan touched on nutrition, so important and often not as well done as it could be within the aged care space. Lots of protein and also any kind of blood pressure related issues. So if you tick all those boxes, I think we're doing pretty good. And now we move on to the bit that's a bit more fun. So exercise and falls. So this is kind of where, I don't know, it's what I'm passionate about. I love trying to get older people moving. Sorry, dry throat. And it wouldn't be one of my presentations without trying to get some audience involvement. So get yourselves ready. You got any stretches and things that you need to do? We're all going to try and improve our balance together over the next kind of 10 minutes or so. So here is some research that came out of Queensland. So Jenny Hewitt is a physio up that way, bit of a pioneer in the fall space. So there's lots of good research around falls prevention and exercise. So you may have heard of the Otago program. The Otago has been around a good while. Progresses, I think it's 17 exercises that show progressions, and some of them we're actually going to touch on. It's been shown to reduce falls by about 30 to 40%. So the Otago is a good one. If you Google Otago, it'll give you some nice base points to work off. Things like Tai Chi can be fun to incorporate into a bit of a holistic physio-based exercise program. But I like this one, all right? I like going to the gym. I like trying to get people moving. I like strength-based stuff. So this was called the Sunbeam Trial. Again, if you Google it, you'll get lots of good information. Jenny's done a few presentations that you can actually pull her slides straight off Google. It has the protocol that she used in order to achieve these results. But essentially, we had about 220 residents across 16 homes. It was a 6-month study. They're basically twice a week for 1 hour. Spent 30 minutes, so 1 hour each time, 30 minutes of balance and 30 minutes of strength training. So they had access to some pretty cool equipment. It's the HER equipment or the pneumatic exercise-based equipment, so relatively expensive. Unfortunately, most of the homes we work with don't have access to those, sadly. But we were actually able to replicate a similar result. So in 2021, we implemented the same principles, but without access to the equipment. We just swapped the leg press for a squat, things like that. And we were able to reduce falls by 48% in a 100-bed home that we worked in. So we know it works. It's just about having the ability to actually implement those programs. So often it's accessibility or time as opposed to anything else. But if we're all working together, hopefully we can all advocate for more allied health funding in aged care. While I'm on my soapbox.